evening, everyone. You are very welcome to the Menopause and Me, the Many Ways to Manage My Menopause webinar tonight. Following a short video, you will be joined on screen by your host for this evening, Mairead Kelly. Thank you.
And it is all change. I mean, menopause is 100% change that I don't think any women are prepared for, really, to be honest, unless you start going through it. But I think it's fantastic to see now that everybody's talking about it, and you know, even the younger people at work now are laughing, saying, oh, we'll have no fear going through menopause because we're listening to all the older women now are talking about it, you know.
Good evening, everyone, and welcome to our Menopause and Me, the Many Ways to Manage Your Menopause webinar 2025. My name is Mairead Kelly, and I'm a Senior Health Promotion Officer here in the Mid West, and I will be your MC for the evening. We are delighted that so many of you have registered and are either joining us live here this evening or are watching the recording at a later and more convenient time for you. Our lineup of speakers for tonight include a number of healthcare professionals who will share evidence-based information to inform, support, and empower us women as we navigate perimenopause and menopause. We also have women from across the Midwest community who will be telling their own stories of their personal experience of menopause. I wish to thank each of them for their bravery in coming forward and sharing a part of themselves with us. They are Siobhan Tuitt, Nuala Wolfe, Margaret Harty, Myra O'Brien, Bridget Harty, Kathleen McCarthy, Anne Noonan, and Anya Collins. And we will hear from them at different points throughout the webinar. We have a very busy agenda here this evening, so to start proceedings, I wish to introduce our Health and Wellbeing Head of Service, Niamh Wallace, who will open the webinar.
Thank you, Mairead, and good evening, everybody. It's my great pleasure to welcome you all to our webinar this evening. My name is Niamh Wallace, and I'm the Head of Health and Wellbeing Services here in the HSE Mid West. It's great that so many of you could join us for the webinar this evening, and I think this is testament to the need for information and education on menopause for women and their loved ones right across our community. In health and wellbeing services, we use a number of approaches that help people to make good decisions about their health. These include delivering clear and correct information, education opportunities, skills development, and the chance to engage in supportive activities and environments. And this evening is about all of those. This evening, you will hear from experts in the field of menopause from our great colleagues in the Complex Menopause Clinic at the Women's Health Hub in Nenagh. You will also hear from different members of our health and wellbeing team and HSE clinical colleagues who will tell you about things you can do to understand and manage your menopause journey. Their expertise will enhance all of our knowledge relating to menopause and relating to ourselves. And I thank all of my colleagues for offering their skills and expertise so readily. When I think of the supports that I receive in relation to menopause, I reflect on the many great women in my life who share their experiences with me. My beloved sister, my close friends, my friends and colleagues in work, my fabulous hairdresser, to name but a few. And this evening, as Mairead said, you will hear from women across our community in the Midwest who will share their experiences and their journeys. I know these stories will resonate with you, and I express my great gratitude to these ladies for their contribution, which is not only brave, but so supportive to each of us. So I hope you enjoy this evening's webinar, that you learn something valuable for you, that maybe you feel less alone in this journey, and that you feel more empowered at the end. Please share your feedback with us. We always want to learn and to do better. And thank you so much again for being with us.
Apologies. Thank
Lovely.
you, Niamh. As you said, the vision for this evening was that having joined us, that you as women experiencing perimenopause or menopause will feel less alone, will feel more empowered, and will understand the many supports that are available to you. So we now have our first community contributor video telling me about your menopause.
one of the flushes, to have flushes, and be like a radiator. You know, like you would get symptoms you could just sitting down and all of a sudden from your toes up to your head, it's like as if you're after turning on a heater and the heat is working its way up. Like it affects so much in your life, you know, between the changes that you're going through, and it can affect your physically, emotionally, so it can affect you in so many different ways. Like,
So would you have sleepless nights?
oh, she would.
So it would affect you, do you?
Oh yeah, you'd have like, there was some nights there and I'd still be wide awake at 5 o'clock in the morning. I couldn't understand why I couldn't sleep. I get up, I get a book, I try and read a book, and I'd be just like someone that's only after getting up out of bed in the morning. I'd just be fully awake.
I think, unfortunately, in the health system and probably in lots of workplaces, there's maternity leaves and people have PRI and people have paternity leave and they have breastfeeding leave and they have every kind of a leave. And the middle-aged woman in the middle of it all who's been there and done all that without any of those leaves is forgotten.
I mean, I knew that what menopause was and whatever, but I just wasn't prepared at all, you know, really. So I suppose it was a lonely journey for me really, because you can't really explain to your husband or your family or what's going on, you know. So I suppose I found myself in a very lonely place because I was kind of cross, and I kind of my personality changed completely really, because I was never cross and I was always kind of a person that went with the flow and easygoing, and you know, and I think all of a sudden my kids were kind of going, my God, what's wrong with Mum? You know, she's, you know, everything was wrong, and little things I suppose are, you know, that were big things that I couldn't cope anymore, you know, that kind of way. So yeah, it was a big change in my life, like that I had no experience of really, you know, so.
So let me introduce you now to the first of our expert speakers, Dr. Cathy Casey, who's a consultant obstetrician and gynaecologist, and also the clinical lead with the Women's Health Hub Complex Menopause Service in Nenagh Hospital. And Dr. Casey will speak to menopause education, what is perimenopause and menopause. And following Dr. Casey then, we will have our second community contributor video sharing what was menopause like for you.
Good evening all. This evening I hope to give an overview of menopause, how it affects us all, and indeed how we can manage it to the best of our abilities. The age of menopause has remained stable over the years, and menopause is not anything new. It has been around since the female species started and we're living up to the 50s. The difference now is that we're living for much longer. We're expected to have a life expectancy of up to about 80 or in the early 80s, so we can spend up to a third, if not more, of our lives without estrogen. And of course, this has its effects. So as mentioned, the average age is 51, and this is often determined by both genetic and environmental factors. There's some confusion about the terminology around menopause. Perimenopause is a time when our symptoms first start, and this can be in the early 40s, sometimes even in the late 30s. Menopause itself is just defined as the last period, and postmenopause is a year or 2 years without periods. Why does menopause happen at all? And the reason is that we are born with a definite number of eggs or follicles, and these decrease right from when we're in utero, but they decrease particularly from our first period onwards. And at menopause, we still have some eggs left, but they're older and they're less sensitive and less responsive to the hormones that we have, and hence our hormone deficiency. So why all the fuss if it's supposed to be a normal life stage? Unfortunately, for a lot of people, there can be severe symptoms, and this can lead to a significant impact on their own health, their relationships at home and at work, and difficulty in coping with life. And the consequences also then of extended estrogen deficiency can be very severe on some people. So what are the symptoms? Well, we're looking at irregular periods is usually the first one that starts. Flushes and sweat, psychological symptoms, sleep issues, headaches, palpitations, weight issues, and effects on our bladder and vaginal area. So let's go through some of these. So the first, as I mentioned, is the irregular periods, and anything can happen with these. You can end up with short periods, longer gaps between periods, heavier or lighter, and a lot of change. And the difficulty is that these changes are occurring at a time when other pathology can be going on in our womb or ovary. So it's very important just to make sure that it is just perimenopausal bleeding and not an underlying abnormality. We're all very much aware of the flushes and sweats. The difficulty is some people think that these can't occur until the periods have stopped, but that's not the case. They can occur long before the last period. About 75% of women are affected by menopausal symptoms. 25% get through without much difficulty. But of those that get them, 30% can be severe, and they can last anything up to 5 to 7 years. They can even reach into our 60s, and in those women, they can also be quite severe. There's a lot of variation between ethnic groups and countries, and often the actual underlying cause of the flushes and sweats can be poorly understood, but there is no doubt that smoking and a high BMI results in increased severity and increased frequency of these flushes. Psychological symptoms can be extremely debilitating. Low mood, emotional ability, anxiety, depression, inability to cope, where we could multitask before suddenly isn't possible, a lot of fatigue, lack of energy. And these symptoms also occur at a time when life is changing for us all. We may be facing retirement, kids have left home, all sorts of issues, other outside stresses that need to be taken into consideration apart from the menopausal symptoms at all. Sleep can be a huge issue. Sometimes we've no difficulty getting to sleep, but staying asleep is the problem, waking up at 3 or 4 in the morning and not being able to get back to sleep. And the sleep can be disturbed purely by the sleep pattern itself, or sometimes night sweats can wake us, or joint aches and pains can wake us. Weight gain, another big issue. Our metabolism changes in our mid-50s. We have an increase in body fat and less lean mass, and we put up an average of about 0.5 kilo per year. Very difficult, because it's all around the middle. And again, memory and brain fog can occur and do occur in a lot of people, and it can be related to poor sleep or just generally issues on its own. The bladder symptoms also quite common, and these unfortunately can continue right through as we age. We can get frequency of urine, urgency where we can't hold on when we want to go, painful urination like burning sensation. We can leak when we cough or sneeze, or leak when we can't hold on, and we can get recurrent infections. From a vaginal point of view, we can end up with sexual difficulties. Because of dryness, because the skin thins out and the burning and the itch, we can end up with painful intercourse and loss of sex drive and sex arousal. Fertility is another issue. If we haven't managed to have gotten pregnant by our late 40s, early 50s, then there's the stress of the difficulty in the ability to conceive. Or if we're trying to avoid a pregnancy and our cycle is very irregular, then of course there's a risk of pregnancy. So contraceptive issues may need to be addressed. What about the long-term effects of estrogen deficiency, as we mentioned earlier, where 1/3 of our lives may be spent in this state? Well, for some people, you can be certainly more prone to cardiovascular disease, osteoporosis, and again, the long-term effects on the bladder and vagina. Just a word about heart disease, because it is very common. It is the biggest killer of us women as we go through menopause. Cancer is much, much less, as you can see in the orange triangle there. But if you ask women what's their greatest perception of the risk of death, all will think that it's more cancer related, particularly breast cancer, when in actual fact, 1 in 4 of us is going to die from a heart related condition. And in many cases, this can be totally preventable. Heart disease and stroke are the most common cause of death of women in Ireland. And as mentioned, 1 in 4 of us will have a stroke or a heart attack. 5,000 Irish women die each year, and most of these will have from heart disease, and most of these will have already gone through the menopause. And we're 7 times more likely to die from cardiovascular disease than we are from breast cancer. And that's a frightening thought. But it's good also insofar as these conditions can be prevented and our risks can be reduced. We think that we're protected from heart disease and that it's a male condition, but in actual fact, it's not. We get it just the same as the men, but we're about 10 years later. The difficulty is we don't do as well as the men with intervention and treatment, mainly because we have different risk issues, more likely to have blood pressure, high cholesterol, we smoke, diabetes, and overweight. And if you look at those conditions, all of those can be managed, and it's up to us to take responsibility for our health to do that. What about osteoporosis? This is what we know as brittle bone disease. Unfortunately, it is a silent disease, and often the first sign of it is a fracture. You can see from the picture here how thin the bone can get with this condition. It occurs in 1 in 3 postmenopausal women and 1 in 10 men, but it can affect all age groups, particularly younger people who have a very low BMI or who have eating disorders or excessive exercising. It has a major impact on our quality of life, as you'll see in a minute, and it is a very significant health cost, both from our own point of view and from the health services. More women die from complications of osteoporotic fracture than from ovarian, uterine, and cervical cancers combined. And the burden is huge and more than all the sites of cancer, with the exception of lung cancer for women. 50% of women and 20% of men will experience an osteoporotic related fracture in their lifetime. And in the first year after we fracture, we have a 20% chance of a further fracture within that 12 months. There are a number of risk factors. Some of them we can't change, like our age, our family history, our stature, but there are a number that we can modify and reduce our risks of osteoporosis, such as smoking, alcohol abuse, exercise, our nutrition, our low body mass, and susceptibility to falls. All of these can be modified to reduce our risks. If we look at what happens to our body with osteoporosis, in our 50s, all seems good, and the first risk is usually risk of fracture of the wrist. The vertebrae can collapse with osteoporosis, and eventually we can become bent over, and therefore there's compression on our ribs, on our stomach, and so we get stomach issues, we can get bladder issues, and of course pain and risk of hip fracture. So what can we do to manage all of this? The most important message I want all of you to take home today is that we need to have a healthy lifestyle. With this, we can ensure a healthier aging process. So a good healthy diet, plenty of exercise, 150 minutes of a brisk exercise per week, no smoking, moderate alcohol, maintaining a healthy weight, and doing our pelvic floor exercises. All of these will maintain healthy bones. It will reduce our risk fractures for cardiovascular disease. It's also important that we participate in all the cancer screening programs, and indeed wear our sunscreen and protective clothing when we're out in the sun if we get it. Unfortunately, despite our good efforts to have a healthy lifestyle, our spirit is willing, but sometimes the flesh can be weak. So what other options have we? Well, HRT is one. And the most important element of this is estrogen. This is the hormone that will reduce our symptoms and indeed protect us to some extent going forward. So estrogen can be given by tablet form or through the skin by patch, gel, or spray. The dose we start at depends on our age and symptoms. We measure the response to it by the response of our symptoms to the treatment. There is no point in doing bloods, they fluctuate so much, so it's really our responsive symptoms. And the length of time we're on it varies for every single individual. As mentioned earlier, most of the symptoms will last for 5 to 7 years, and that's our usual time span, but it is not written in stone, it's very much individualized. Because we give estrogen, it can aggravate the lining of the womb, so we need progesterone to counteract that. And depending on where we are with periods, if we're still getting periods, then we need to give the progesterone in a cyclical manner for either 12 or 14 days in the month. But if our periods have stopped for more than a year, or if we're over 54, then we take progesterone continuously. We usually try and use the most natural progesterone, which is the least side effects and the least effect on clotting. And again, depending on where our periods are, your doctor will decide how much of it you need. It can be given in tablet form, through the skin, or with an intrauterine device called the Mirena. And the Mirena is the only one that's licensed as part of HRT. I mentioned testosterone because it's out there a lot on social media as working and improving lots of symptoms. The only symptom that testosterone is researched and evidenced for is loss of libido. It's not licensed for women. We don't have any for us. We have to use the male testosterone in a diluted dose. And it's very important that blood levels are checked before you start, and again at 6 to 8 weeks later, and at 6 months. And if it hasn't had an effect at 6 months, it's not going to work, and we stop it. What about our vagina and bladder symptoms? Well, pelvic floor exercises are very important. We can use local estrogen cream or tablet or a pessary. And there's also vaginal moisturizers, lubricants, surgery if needed, particularly for any prolapse. And there's laser treatment, which works well for vaginal dryness. Unfortunately, with all medications, there are side effects. And these can be quite common, but will usually resolve within a couple of cycles of taking treatment. If they don't resolve, then it's a matter of just altering around maybe the way we're getting the hormones or the dosages. And the most common side effects are breast tenderness, headaches, nausea, leg cramps, fluid retention, some irregular bleeding within the first few months, and mood swings. There are also contraindications, or these are very important. There are some women who cannot take HRT and should not take HRT. And those are ones with a hormone-related cancer, or if they've had a clot in their leg or their lung related to pregnancy or the pill. So for those, there are other treatments. We have plenty of options for managing menopause. And there are a number of drugs listed here which work very well for menopausal symptoms. And deciding which one will depend on the symptoms that are being presented. Some of them, however, will react with medications that patients may be on or may affect the liver or the uterus, particularly St. John's wort and black cohosh. And we prefer to avoid these if at all possible. Again, if people are taking other drugs, it's very important that your doctor knows that so that they can decide on which one is important for you. Lifestyle treatments like acupuncture works well, but the best of all is cognitive behavioral therapy. And that has been shown to significantly reduce menopausal symptoms. Sex therapy is also of benefit for those with sexual dysfunction, and relaxation is certainly good for all of us all of the time. So really the risks of taking HRT, as mentioned in some people, is breast cancer, getting a clot in your leg or your lung, but certainly the clotting issue can be resolved and reduced by taking the hormones through the skin. The main risk out there is all the myths and misconceptions and misinformation that's out on social media. So it's very important that you get adequate, up-to-date and evidence-based information so that you can make a decision as to which treatment is best for you. The benefits, of course, as we've mentioned, are the symptom relief, osteoporosis reduction, cardiovascular reduction, and colorectal cancer reduction. That's bowel cancer. Just to show you from the point of view of putting the risk of HRT with breast cancer into perspective. If you look at the average risk for getting breast cancer in somebody between the age of 50 and 59 and taking HRT over 5 years, there is an extra 4 cancers per 1,000 women taking HRT. Same as with the pill. If you look at taking more than 2 units of alcohol per day, it's an extra 5 cancers per 1,000 women. But if you look at somebody who has a high BMI of over 30, it's an extra 24 cancers per day. Huge increase. So it's very important that the risks are put into perspective with other aspects of our life. And if we exercise, there's a reduction, significant reduction of 7 cancer cases per 1,000 women taking HRT. So exercise, lifestyle, and diet, very important. So basically, when do we start HRT? When the symptoms occur and if they're interfering significantly with your quality of life and your ability to cope. The treatment depends on the type of symptoms, whether or not we're getting periods, and whether we need contraceptive needs or not. If we're postmenopausal and getting symptoms, then there is certainly a window of opportunity where we're 10 years less than from menopause and under 60, where it has significant beneficial effects. But the biggest message is all of this has to be individualized. So it's looking at the right medication for the right patient at the right time. And as we said, benefits from primary prevention of osteoporotic fracture, heart disease, and a reduction in all-cause mortality for women who take it at the right time. So every woman will transition through menopause. They'll experience menopause differently. Many are unaware of the realities of menopause and the debilitating effects on all aspects of a woman's life, but it does not have to be that way. With the right education and support, everyone can be equipped with the wherewithal to deal with their menopausal symptoms. Thank you.
I suppose, like, growing up, it was never talked about at home. I suppose me, my age, and going back years ago, my mother never spoke about it. And, like, I kind of don't speak about it either myself. Although sometimes I would throw a few hints when they're giving out about me giving out. And I'd say it's coming to you, you'll know what I'm about when it comes to yourselves, like.
But I think the loneliness and the sense of self-worth was the worst for me. Is the lack of identity and the lack of self. I felt very much a non-entity, that my role in life was gone and it was a purely hormonal, that my sense of self was just not there. And I think that's the biggest thing that is not spoken about in women going through the menopause.
So I was low and I was kind of full of anxiety, and even my driving, like even driving at night time, I was kind of like, God, I can't really do this, which never featured in my life. I would drive and, very confident, and lack of sleep, and I suppose I wasn't really functioning great, Still, like, you're still trying to do your everyday thing. You're trying to mind your family and keep up your job and worry about everything else,
Thank you, Dr. Casey. That was very informative. And to our community contributors, their sharing of their experiences really will strike a chord with many of us here this evening. Our next speaker is Aisling Mulcahy, who is a clinical nurse specialist with the Complex Menopause Clinic. And Aisling will outline what the clinic is and who it is for. And then immediately following Aisling, we have Anya Collins, who will speak and share of her experience as a service user of the Complex Menopause Clinic.
Hi, thank you for joining us here this evening. So I'm Aisling and I'm part of the Complex Menopause team in Nenagh. I work alongside Dr. Cathy Casey, who you've just who's just spoken, and Dr. Brian Kennedy, who's speaking in a few minutes, Dr. Khadija and Amanda, our administrator, and obviously myself. So who do we see in the Complex Menopause Clinic? So we see ladies who have a complex medical condition, like a breast cancer, maybe a gynae cancer, maybe they've had a heart attack, maybe a clot, maybe a stroke. We also see ladies who have experienced a premature menopause. That would be somebody who's had menopause before the age of 40. And we also see ladies with a very strong family history of premenopausal cancer. And what we mean by that is if you have a close relative, a sister, a mother, who they had a breast or a gynae cancer before about 50, we see. So who do we see and who do the GP see? So we only see 5% of women. So most of you here tonight will be managed very, very well by your GP if you're experiencing any symptoms. And Dr. Kennedy is going to speak to you all about that later. So how do you refer to us? So we see ladies from the Mid West. So we see Limerick, Clare and North Tipperary. Your healthcare professional can complete the referral and either they can post it to UHL, central referrals at UHL, or your GP will be very familiar with using HealthLink and sending the referral that way. So once you get offered your appointment, we send you out a questionnaire in the post. So it's really helpful if you can fill out this questionnaire to the best of your ability. It just really helps when you come into us to kind of know what's the most troubling symptoms that you have, and it helps to focus the consultation. So what can you expect when you come into us? Well, you'll meet one of the doctors or myself. We'll go through a very detailed history with you. We'll discuss all the options available to you. We may need to do an ultrasound. We may take bloods. It'll all depend on the day. And if you need a prescription on the day, we'll give you that. So if you're sitting there and you're thinking, I don't want HRT, and or my doctor said I can never have HRT, can I still attend? Absolutely, you can attend the clinic. It's not a HRT clinic. Yes, we do prescribe HRT, but that's only one thing that we do. So are there side effects? Yes, and Dr. Casey mentioned some of those. And if you were with us, we will go through all that with you, whatever we decide to prescribe with you on the day. And What kind of options are there to treat my symptoms? Well, that's what tonight is all about, really. There's so many different ways to treat symptoms of menopause. And we like lifestyle, diet, exercise, psychological therapies, complementary therapies, hormonal and non-hormonal medications. And that's it. Thank you for listening.
So I was thrown into an overnight menopause, a surgically induced menopause. It's what it's medically known as. And I had a diagnosis of ovarian cancer. So I had both my ovaries and my womb removed. So for 2 years, I went from diagnosis to operation to chemo to operation. And at the time, you're just getting through all of those things, even though you would hear about the menopausal symptoms and you think maybe is it or isn't it, but I didn't really come to terms with my symptoms being menopausal symptoms until everything else finished. And then I could think about it, okay, I am in the menopause. And then I said, right, okay, we need to go and do something about this now. It was, for me, the predominant symptoms were brain fog, not being able to feel like myself again, tiredness, the bloating in your stomach. But it was mainly the brain fog. Somebody standing in front of you and it's like, I can't remember her name. Stuff like that. And the whole sense of being overwhelmed, everything was overwhelming. And yeah, just not the mood, not being great. Yeah, and then obviously there was the vaginal dryness piece, there was, you know, the painful intercourse, all of that as well. For me, I had a cancer diagnosis, and that, you know, I grew up in a time where you don't go near HRT. HRT is not good for you. HRT may cause cancer. And we all know that that's not true now. But I grew up in that era and I never heard of anybody taking HRT. None of my relations did. I decided, right, I have to get more information at least. So that's the route I went down first. So I talked to my gynaecologist, I talked to my oncologist, and I talked to my GP, and I heard about the Complex Menopause Clinic. And this was like manna to heaven for me, because it was somebody that understood what I went through. It was somebody that specialised in somebody with a history that I have. So I was blessed to get an appointment in the Complex Menopause Clinic in Nenagh. And I met Dr. Cathy Casey and I met Aisling, Mulcahy, the CNS, and everything came together then. She changed around some of my medication and I have not looked back since. It's just an absolute godsend, the Complex Menopause Clinics.
Thank you both, Aisling and Anya, and a special thank you to Anya for sharing your own personal journey and sharing the support that you received from the Complex Menopause Hub. Our next speakers now are Charlene Hyland and Michelle Maher, who are clinical specialist pelvic floor physiotherapists, and they will speak to menopause and your pelvic floor. And we might also have an opportunity to practice some pelvic floor exercises during this presentation. And immediately following this, we will have Nuala Chute, who is a service user, who will tell us about her experience of using this service.
Hi, my name is Michelle. I'm a women's health physiotherapist here in Nenagh Hospital, and I'm going to talk through how menopause can affect your pelvic floor. So just firstly, I want you to have a little visual of your pelvic floor structure. And what you can see in the image here is your bladder towards the front, your womb in the middle, and then your bowel towards the back. And underneath those organs, you can see a sling of pelvic floor muscle that is designed to support these areas. These are all responsive to changes in the levels of estrogen as they decline throughout the lifespan. These changes can result in the following conditions happening. So things such as your tissues becoming thinner, they can become less flexible or elastic. You can find there's less lubrication in the area. The ligaments and muscles that support the area can become less supportive with the decline in estrogen. There's also a rise in the pH levels, and this means that your vagina can become more acidic, and therefore there's a change in the balance of both your good bacteria and your bad bacteria. This is known as the genitourinary syndrome of menopause. The vaginal symptoms that can be experienced include dryness, which can result in UTIs. You can experience itching in the area. You can experience atrophy, which is a decline in the muscle bulk in the area, and then also dyspareunia, which is painful intercourse. The urological symptoms that can occur include urinary urgency, which is kind of a strong sensation that you really need to pass urine. You can become more frequent in your visits to the toilet. The actual experience of passing urine can become more painful, and you can also experience urinary incontinence, which is leakage of urine. So what can pelvic health physiotherapy do? Well, we have a team of clinical specialist physiotherapists located throughout the Mid West who can help manage these symptoms. You can be referred with any bladder or bowel dysfunction type symptoms, including leakage, prolapse, painful sex, and overactive bladder. You can have your GP or your gynaecologist refer you into our service by sending a referral with your symptoms on it into a central referral hub in Limerick, and then you will be located to a physiotherapist in your area. We can provide education, lifestyle management, and advice on keeping a healthy bladder and bowel. And a large part of our treatment will focus on your pelvic floor in order to make it work correctly for yourself. I'm now going to hand you over to my colleague Charlene, who will take you through how to do your pelvic floor exercises.
Up to 74% of women will notice a significant improvement in their symptoms of leakage with pelvic floor muscle training. Let me take you through a pelvic floor exercise. Firstly, there are two types of muscle fibers in your pelvic floor, fast twitch and slow twitch. This is why there are two types of exercises that we need to perform, our slow squeezes and our fast quick squeezes. Let me take you through a slow squeeze contraction. Begin by placing one hand on your tummy and your second hand underneath your bottom around your back passage. Begin by breathing in and feel your tummy muscles rise and your pelvic floor will be relaxing. Now, as you breathe out, I want you to gently squeeze the muscle around your back passage. Imagine you're stopping wind, and at the same time, squeeze around your front passage. Imagine you're stopping the flow of urine. You should feel a squeeze and lift up. Now, breathe in and let go, and you should feel the muscle fully relax. And this is your pelvic floor slow contraction. You should aim to do this exercise up to 10 times. Begin by counting to 5 seconds, and as you get stronger and more confident, you can build this up to a 10-second hold. The important points when doing your pelvic floor exercises is that you do not hold your breath and you relax the muscle fully after each contraction. The fast, quick contractions can also be done after you've done your slow contractions. A good position to start your pelvic floor exercises is in lying or sitting, and then gradually build up to standing. It's important, if you're having any problems or are not sure if you're doing this correctly, that you get a referral to our pelvic health physiotherapist. The next presentation will be from a patient who has experienced coming to our pelvic floor clinic here in Nenagh Hospital.
My doctor is very good. My GP is very friendly and very informative and really wants to help. Through him I actually went to the menopause hub. He referred me to the physiotherapy service there, and I didn't know what to expect. But when I met, my physio was Michelle. She was just so lovely. The consultation assessment took an hour. I just couldn't believe she spent that much time with me. And this was like a chat with someone who really cared and was really listening. And she went through all of my symptoms, and then she asked me, could she examine me internally, which nobody has ever asked could they do before. And that was actually so good because to get the reassurance for a professional that you're not falling apart when you're in menopause. You know, I was glad to know that things weren't going to get worse, because I think that's always at the back of our minds, are things going to get worse? So I feel a lot more confident because of that. I think it made me realise that, like Michelle said to me, basically you should be doing these Keeling's exercises all through your life as a woman. Because like going to the service, like the menopause hub and to the physiotherapy, I think at this stage in your life it's like having an NCT when you're kind of an older car and you just want to make sure everything's running well.
Thank you to both Michelle and Charlene for that, and especially the practical piece and guiding us on how to do our pelvic floor exercises correctly. And also a big thank you to Nuala for sharing her story. I now wish to introduce you to Dr. Brian Kennedy, GP and menopause specialist, and Brian will inform us on what your GP can do to support you.
Hi, everybody. I hope you can hear me. So I'm Brian Kennedy and I work with Cathy and Aisling in the Complex Clinic, and I'm a GP on the other days of the week. And so I'm going to talk today about what you can do to get the most out of your GP consultation. So this is a picture of the female genital tract. So the ovaries are represented by the boxing gloves, and the womb and the cervix are lit up in fluorescent lighting. And it's just a reminder that sometimes it is still a fight just to get basic health care if you're a woman and you need some women's health advice. So it can be hard to access it. It can be hard to get timely care. And sometimes it can be hard to get someone to listen to you. And so like women will have gone through the reproductive years dealing with contraception and, you know, bearing the big burden of reproduction in the human life cycle. So they'll probably build up a very good relationship with their GP, etc. So they'll be used to dealing with their GP and used to dealing with periods and ovarian cysts and problems with your menstrual cycle, be it heavy periods or missing your periods or your periods being painful. So they go through all that and then they turn around and the ovaries start to fail, and it goes from being all lit up and boxing gloves to black and white, and it's as if your ovaries give you two fingers and they start failing on you, and you can get these years of perimenopause where you can feel this kind of daily kind of difficult PMT, and you're cranky and you're not enjoying the kids and you're finding work difficult, and as the previous speakers were describing, losing confidence and generally losing your mojo and still having to deal with periods sometimes. And then you go to the GP and so they will often say that, you know, oh, you're still having your periods, it couldn't be menopausal, but you could be very perimenopausal and still having your regular cycle. So it's worth having a trial of some estrogen to try and stabilize things out for you. And just to remind that not everyone's menopause is terrible. So 20% of women cope quite well with their menopause. 20%, however, have a terrible time, and it's nearly like a really severe illness that's both physical and psychological. And they really do need help because the symptoms are so disruptive and affect them holding down, you know, the basic day-to-day, their relationships and their work and their basic tasks, etc. So what are the challenges? So what's lovely about the Davina McCall Channel 4 documentary is that she shone a light on the menopause, and then that kind of that lit up the radio airwaves here in Ireland quite quickly afterwards with the Joe Duffy show. And for 2 or 3 days, everyone was talking about menopause. And it kind of all happened in the middle of COVID, in the middle of a very difficult time for GPs because there was all sorts of crashes with the IT systems, etc. And we couldn't link to the labs, and it was all a very difficult time. And but what we've learned from that is that there's been a huge explosion in demand and people asking for care and asking for attention around their menopause symptoms. So we should be making sure that people can access their care where they need it, when they need it, and that no one should be suffering in the shadows and secrecy, and that people should realize that if you're in the perimenopause, you can have very strong symptoms and it's not going to be reflective in the blood test. So the blood tests don't reflect it. So the GP has to believe you and has to kind of give you a trial of the hormones. And that can be a difficult one to nut out. And we need to start believing women when they tell us about their symptoms. So people have talked before about having their ovaries removed and having that awful surgical menopause where you wake up in this florid, difficult menopause, and that shouldn't be happening if the woman is able to take HRT. So we should be predicting that need. And just to point out, those young women, so under 40 is a different entity. So if your hormones are taken away 10 years before everyone else's are under 40, you're at a much higher risk of those things like heart attack and stroke and osteoporosis. And we see that women don't really get heart attacks as young as men, and they live that a little bit longer. And it's because the hormones protect their arteries. So if you protect the arteries to your heart, you don't get heart attacks, and protect them to your brain, you don't get stroke. And we all know that if you fall and break your hip when you're elderly, that leads to one thing after the other and long hospital stays, and it can often end up killing older people. So we have to be mindful of that HRT can do a lot of good. And the average woman that sits in front of the average GP is going to benefit from HRT. And I'm talking about the lovely new modern HRT that we have, the gentle one that dovetails in with your natural hormones. It's a discretionary medication, so it's not like insulin. If you don't get it, if you're diabetic and you don't get your insulin, you're going to die. It's a discretionary medication, but it's a medication that can really benefit women. And it's important to match the patient to the medication and to the intervention. So what's the first port of call? So sometimes it's very unreliable sources or Instagram or TikTok. Sometimes it's the practice nurse, sometimes it's the GP, sometimes it's the gynecologist or the pharmacist or their friends, sisters, mothers. Sometimes it's in family therapy because relationships can break down. Sometimes it's from the oncology because for difficult medical reasons, maybe with breast cancer or hormone-dependent cancers, their ovaries have to be removed. It can be sometimes from a psychiatrist. So some people can get very, very depressed in midlife, and there's a peak in suicidality in women at around the age of 51, and it has to be related to the menopause and the change. So it can be a very trying, difficult time, and women can present in all different circumstances. They can present to the endocrinologist, who's the specialist in hormones. And some women could say that if you don't do something about my menopause, I'm going to end up in prison, and that's where you'll find me. So it can be very, very difficult and very, very serious. So when do women come? So everyone knows that, from the movies and soap operas, you'll see insomnia, not sleeping, the night sweats, the flashes that are disruptive. That's what people associate with the menopause. But there's all sorts of weird and wonderful things, from burning mouth and numbness in your body and all sorts of other symptoms that come. And sometimes they come with fear of missing out because they meet their friends or their sisters and they're doing so well on HRT. They want to be as well as them, and they come in looking for it. And sadly, still, because women are basically keeping the whole show on the road, they're the ones that are keeping families together and doing everything to kind of solve problems within their families and within work. They often come framing how they are failing others. So they often say, I'm failing my husband, there's no sex happening anymore, their children are noticing they're cranky and they're tetchy with the teenagers, they've got the brain fog and the poor decision making, the reduced job performance. And I found, as Siobhan said earlier, that driving on the motorway, that's actually classic. So confident drivers would think nothing of driving up to Dublin, suddenly are daunted by the motorway and don't want to go on it. And I had a woman recently who had bad dyslexia as a teenager, and she had a job where she had to write down things every day and list out things. And then all of a sudden, she just woke up unable to spell. Everything was spelled backwards, and her dyslexia just reared its head. And often you find that, like, if you were clumsy as a younger person or if you're a little bit anxious, it often comes out and worse in those perimenopausal and menopausal years. So the girls have already spoken about these the climactic scale. So this is a lovely thing you can do to your GP. And actually, you can do, and before you go into your GP, because if I did this scale on myself, not being menopausal, just on an average Wednesday after 3 days of general practice and everyone roaring and shouting at you and giving out to you, I'd nearly get upset. But what I think is very useful about it, that if you go through it, it kind of takes the emotion out of the consultation, and you kind of go in with kind of the cold fury of, I want to be moved forward. I want someone to listen to my symptoms and get on with things. And it's lovely to have documented it. So not everyone gets on with the HRT. And when someone comes in and they say, look, I'm trying HRT, and now you get the very common side effects of sore breasts and unscheduled bleeding, you can go, well, hold on a wee second now. This is what you came in with. And you can actually go through their symptoms and actually see, are we having fun here? Was life better on or off HRT? And I think it's very useful to take that time for yourself, get it on paper. And sometimes it's nearly getting the rage on the page. You kind of have it out of you then. And then when you go in to see the GP, you're ready to have a kind of clear, cogent conversation. So GPs are absolutely mithered from menopause care because there's been an explosion in people looking for care. And the problem is that intergenerationally, HRT has changed. So 30 years ago, it was put it in the water. Then 20 years ago, they studied a lot of women taking very strong HRT derived from horse's urine. Now, that HRT was a fabulous HRT. It was very strong, but it meant that women got a lot more clots, and they gave it to older women. So a lot of the studies are actually on they're not our women. They're not the women that come to us in their 40s and early 50s. They were women that they pulled off the street in their 60s and to see how HRT would suit them. And thus and therefore they discovered that there was more strokes and heart attacks in these older women. So we need to avoid that HRT. So modern HRT is all about these lovely bioidentical, very similar to the hormones your ovaries produce, much safer. We can deliver them through the skin. They're not associated with clotting. They don't increase the risk of heart attack and stroke, and they're much more accessible to, and they're much more safe to prescribe. So your GP, every GP is well able to prescribe HRT and has learned about HRT. And hopefully when you go see your GP, you're going to be met with someone who's trying to solve your problems, empathize with you, kind of move you forward. And they will know you from your other attendances. But sometimes they will perceive risks when starting HRT, and they might get a bit antsy if you have maybe cardiovascular disease. So if you've had heart attacks or strokes, as Ashley was saying, you should be in the complex clinic. If you have severe migraine, it can throw GPs off because it can make, it can be hormone related, so they might get a little bit antsy about it. And certainly if you have very strong family history of breast cancer, sometimes it can make it into a very complex conversation that the GPs might feel, look, is best handled by someone who's a more experienced prescriber. So if they feel there's a very high risk, they'll send you on to those complex clinics. And it's great to have them now. So we have our complex clinic running in Nenagh for the last 2 years about. And, it's great that we're able to service that need that's there for women with complex stuff. But when you approach your GP, it's a good idea to have researched good resources. So it's not going with, well, my friend Bridie is on this and that's what I want. It's lovely if you can read the kind of evidence-based stuff. So the HSE have lovely information online. There's a great evidence-based website, the Women's Health Concern. There's loads of very accessible, readable information on that. NHS in the UK has lovely information as well. And if you get your form filled, you're taking a good chunk out of that consultation. I think some of these consultations are complex and they're long, and it's worth maybe warning the GP before you go that you want to have a menopause consultation, because the first one is often very long, and in my experience, it's at least 40 minutes. And if you know the patient, even it often is 40 minutes or longer. So you should warn the receptionist, say that you want to talk about your menopause, and usually they'd have the sense to double book you for 2 appointments. Or maybe they mightn't be able to get to it all in 1 appointment, but they will do their best. And if there are some GPs who aren't that confident about menopause care, you might get directed to the GP that's most confident with it. There are brilliant practice nurses out there that are excellent in menopause care as well, and they're going to all the conferences as well. So don't underestimate your practice nurse. Of course, if you have a medical card and you only have one doctor and your doctor isn't very confident with it or gets worried about it, you're going to have less choice. But a lovely option that we have locally is the Limerick Family Planning Clinic, and medical card patients can access that free of charge, I'm almost sure. So I looked at the website today and there isn't a charge, but they would have limited slots and you'd have to warn them as well. Of course, if you're a private patient, there's probably a lot more options with GPs who have special interest and do private consultations, or of course, there's a few menopause specialists locally. If you go into GP all guns blazing, and sometimes women can come in all guns blazing and they say, I want this HRT and I want it in the gel and I want this, and they know what they want and they're very clear. That can be very helpful in one way. But I suppose if I went into my friend who's a teacher and told them how to teach 5th class or whatever, I know what I'd be met with. So it's more about kind of a collaborative approach and setting out your needs and advocating for yourself. But I suppose sometimes in general practice or in any medical setting, your job can be to tell your patients stuff they don't want to hear, or cautions they don't want to know about, or medical concerns you might have about them. And of course, menopause doesn't happen in a vacuum. So if you're going through a divorce, if you have lots of trouble going on at home or at your job and you're stressed, that's going to affect how you deal with your menopause. And also, a difficult menopause is going to affect how you deal with holding down your job and holding down your relationships and getting on with your life. And sometimes people think HRT is going to solve everything, but the GP is a generalist and they're going to see the big overarching picture, and they might know you better than you know yourself sometimes. And then the other side of it is sometimes you can feel dismissed, that they kind of know you too well and they feel this is your depression or this is your stress, and they don't listen to you when you're talking about perimenopause. And so we would see women like that feel that their GP just wasn't really able to hear their concerns, or that they wanted to try some hormones. But all the guidelines, so from 2015, it's all about this respectful, individualized care that endorses modern HRT prescribing in women who will benefit from it. So these are our newer products, our gentle, bioidentical, very biosimilar, very similar to the hormones that your own body produces. So it's the estradiol and the eutrogestrone or the micronized progesterone. So it's very rare that there's a full contraindication or a reason why you absolutely can't take these hormones. So, and especially if you're using the transdermal route, which by that we mean the stuff that is applied to the skin, so in patch or gel or spray. So that doesn't increase your clotting in the lower doses that we use nowadays. And so it's actually very safe in most circumstances. And we've moved away from that bad press HRT, that one that was derived from the horse's urine. So they used to get pregnant mare's urine and get this really strong HRT from it, which was a fabulous HRT if you took it because it was so strong and it made you feel much better. But with that, there was a lot higher side effects. So it was generally oral HRT. And when you take oral HRT, that's processed by your liver, which increases your clotting factor production, which in turn increases your likelihood to have clots and makes your blood thicker. So we worry about cardiovascular events such as heart attack and stroke. So nowadays we've moved away from that to really gentle, modern, gentle HRT that dovetails in with your own system in a much gentler way. So this consultation, it's a life-changing consultation. And for me, I have to say that most consultations around menopause are actually very, very positive. So it can be a very positive consultation for a major life cycling event. But women, when you come through the change in life, it can lead to somewhat of an existential crisis. And what I mean by that, you're kind of going, like the song, The Fleetwood Mac, Can I Handle the Seasons of My Life? It really sets it in stone that perhaps your body is changing and that your biological function is changing and you're moving away from reproduction to the post-reproductive part of your life. And that can make you really look at your life in a very in a way that kind of takes stock. And that can be upsetting in some ways, it can be empowering in other ways. And I suppose what we're all thinking about is the future. Everyone is aging. The life expectancy of the country is getting longer and longer. A lot of us will expect to live into our 80s. And for many women, they might live far longer than their reproductive time. So if you get your period at 10 and it's gone at 50, you could have 40 more years, which is the same time that you were menstruating, that you have to be living. And it's all very well to be alive, but we want to be well and we don't want to be frail. And I think we have to be ready for that grey wave they're talking about, that the whole country is going to be aged. And when we look, there's going to be far less young people compared to the amount of old people. And I suppose all of us want to age well and we want to be as strong as we can be. And I would hope that modern HRT prescribing is going to be part of that arsenal, or that stuff that we can do to make ourselves be as well as we can be. Because if you look at the bigger picture, HRT helps protect your arteries, to protect against a heart attack, protects against stroke, protects against some of the dementias like the vascular dementias, and also will keep your bones free from osteoporosis, hopefully. And that will mean that you'll be much sturdier as you get older. And when you fall, you're not going to break your hip. And we all know that when you fall and break your hip, one thing happens after the other. It leads to pneumonias and heart conditions and frailty. And sometimes you end up in residential care. So there's lots of things they could do to keep things simple in the approach to your menopause consultation, but they're going to focus on the things like screening and make sure that your breast screening is up to date, your smears are up to date. Some of the practice might offer pre-consultation questionnaires so that they can be ready, or the practice nurse can help you fill them sometimes, so that we can know the basic background things like the breast cancer in your family, the clotting risk, how you got on with hormones in the past, what your contraceptive needs are, etc. Sometimes it's helpful if you have a patient who's very interested, wants to do some pre-reading. You could signpost them to really useful podcasts and NHS resources. And there's a lovely website for the women's hospital, the maternity hospital in Cork, and they've got really good information on that, and the Ireland Southwind CUMHHC.ie that I've written there. But there's other ones, the Primary Care Women's Health Forum.org and menopausematters.co.uk kind of good stuff on it too. And I suppose for the woman, it's good to set out the stall. So some women will feel very strongly that they want to try HRT, and some women can be very anti-HRT because they are worried about the side effects, or they have had friends that haven't got on with it, and they want you to focus on non-hormonal products, and that's fair enough. So and we're all dealing with what we want to look forward to, is kind of having an adult interaction with our patients and listening to their health concerns and fears and their wishes. And so if someone is saying absolutely no HRT, we listen to that, and there's lots of products that we can focus on. But just because you're veering away from HRT, not all the non-HRT products are that simple, and they all have their own side effects and risks. And so it's a complex decision and sometimes a complex conversation that you need to have someone who knows what they're talking about. I say in practice when you're navigating the consultations with women that come in is that they're often just absolutely delighted to be heard and to actually be given some space and time where you're holding space for them just to describe how they're feeling at this time in their life. And it's funny because sometimes you can hear some very misinformed kind of stuff about HRT, some very pro, some very anti, and some women can be very just like, out of my way, I'm getting HRT, this is what I need. And, you know, not everyone needs HRT, and hormones aren't everyone's friends. And sometimes women do get intolerable bleeding and that bothers them vaginally when they start HRT, or they get very severe breast tenderness that they don't tolerate. And sometimes you do have to look at things, are hormones your friend or not, or should we reconsider what we're doing here? Most GPs you'll find are super receptive and they're very on the ball with HRT now because it's so current and there's so many updates going on, there's so many talks and there's so many resources available for learning. But some GPs still fear HRT, and the problem is that if you practiced 40 years ago, 30 years ago, they were putting HRT practically in the water, and then there's been a full kind of unlearning of that, where HRT was, public enemy number one, and we were deprescribing and taking women off it and convincing them they don't need it. And now there's kind of a full circle thing going on where you have to kind of unlearn all of that. And it's actually the hardest thing in life sometimes is to unlearn things that you have accepted as truths from that bad press studies, from a very different, stronger HRT, not the modern, gentle HRT that we prescribe now. Some patients just simply fear HRT and they're not going there. And that's fair enough. Sometimes you just listen to them and you see what the options are and you try and direct them as best you can. I've made the point that when menopause doesn't not occur in a vacuum, and it's still, your experience is going to be still colored by all the other stuff that's happened to you to date, all your other health concerns, all the other worries about your relationships and your job and everything else that's going on in your life. And some women want just HRT to solve everything and for it to be the panacea. I'm going to take this gel and this tablet and that's going to solve all my problems. And that's not holistic medicine, and that's not true either. So it's not going to solve your marriage problems or your work problems. So sometimes we're dealing with toxic positivity, that it's going to be the cure for all ailments or the elixir of youth. And some women nearly think it's going to be, like that movie with Goldie Hawn and Meryl Streep, Death Becomes Her, and they take the syrup, the elixir of life, and suddenly they look down at their middle-aged bodies transforming back into teenage bodies, and their waists are shrinking and their breasts are rising. And so HRT is good stuff, but it's not that good. So sometimes you have to manage expectations. So if you've background depression, you're still going to have a little bit of background depression. It's not going to solve all the problems with the social interactions in your life and your difficulty with work and relationships. It probably make you a lot better because you're going to be sleeping better, you're going to feel better, you'll probably have more energy and you'll cope better, but it's not going to solve all your problems. So HRT can also be associated with toxic negativity and the cause of all ailments and the elixir of death, and it's going to give everyone breast cancer and all of that, which is completely untrue. And I always take out this, it's from the Women's Health Concern, that website I was talking about earlier, and it shows about breast cancer risks and understanding the risks of breast cancer. And if you look there, like things that are very important are, not exercising is really bad. Being overweight or obese. Look at all the purple ladies there, all the extra cases of breast cancer per 1,000 women over 50 to 59. So if you see with estrogen only HRT, there's 4 less. If you add in progesterone to HRT, which you need, there's 4 more. And then if you look at, like, we actually discount, like, drinking every day is bad, not exercising, being sedentary. So there's lots of other things at play when you talk about breast cancer and breast cancer risk. So we have to, sometimes it can be a complex discussion trying to help women to understand that. We have to manage expectations, contraception, and their cycle. So HRT is fabulous as symptom control. So it'll help with your sleep, it'll help with your flushes and your night sweats and all of that. But it isn't going to solve all of your other health problems. And sometimes we have to warn women all the time that if you start HRT, you have to soldier for a little while, because it's very common for the first few months, especially, to get unscheduled bleeding. So to start spotting vaginally, and also to get breast tenderness. And HRT is fabulous at symptom control from that estrogen deficiency stuff, so the insomnia, the sweats and the flashes, but it is not great at really controlling your cycle the way we'll say the pill is, the contraceptive pill. And we're often kind of managing the picture what are the other medical issues or life problems. And I often think of that Brené Brown. She often describes, people when they come and they have emotions or reactions, that they've got a biology, a biography, and a backstory. And oftentimes you're dealing with women in their late 40s, early 50s, where they're that double deckering. So they're looking after aging parents and often teens and young adult children, and sometimes babies, because lots of women have children in their mid 40s now. So, they have all the other stresses going on. There's also a lot of toxic positivity about very high dose HRT, and that causes this danger of tachyphylaxis. And tachyphylaxis is when you use very high doses of hormones, the hormones are actually not as effective anymore. And so women that really push it up high, you actually sometimes end up getting rebound kind of menopause symptoms. And to get them better, you actually have to take them completely off the hormone for a couple of weeks, let them have loads of symptoms, and then to reintroduce it at lower dose for the hormone to start working again. So you have to be very careful about some of the toxic positivity online. We've talked about the breast tenderness, and then just to remember that the stuff that goes through the skin, the estrogen that you absorb through the skin, the spray, the patches, and the gels is a completely different ballgame to the oral HRT, which is much more associated with thicker blood and stroke, heart attack, and clotting risks. And there's lots of options that, some contraception, and in your 40s, you're often dealing with that perimenopausal stage where you could still produce the odd egg and there's still a risk of pregnancy. So we don't actually stop all contraceptive until 55. Everyone can stop at 55 under the new guidelines. But under 50, we generally like a woman to have no period for 2 years before we can kind of reassure them that she can stop. And over 50, they really need to have no periods for a year till we can reassure them that we can stop. So sometimes then we have to introduce things like the Mirena coil, which is a wonderful invention in many ways, and it stops your bleeding. It gives you contraception for 8 years. It can treat your heavy menstrual bleeding for 5 years, and it can be part of your HRT, so the endometrial or the womb protection part, for 5 years. And it can really help those women that are in that kind of I stepped in and I stepped out again, still worrying about fertility, but with competing menopause issues. And then for the younger women in their 40s that have that perimenopause, so still bleeding, but really perimenopause, the odd flash and stuff, but they also need contraception. Some of the pills, especially the pills that have the estradiol, not the strong ethinyl estradiol, which is the kind of synthetic estrogen, but the kind of more natural estrogen pills, can be really helpful. And I suppose we're always managing expectations. So from the serenity prayer, courage to change the things that can, wisdom to know the difference. And we have to be careful. Like, HRT can't solve everything. And there are some people that have to stop their HRT because they get complex medical issues. So the GP is going to take your history, go through how you got on with hormones in the past, your contraception, how the pregnancies were, your fertility issues, your mental health. They might talk about your bone health and do FRAX scores and maybe think about DEXA scans to see how dense your bones are. They're going to look at your previous tolerances or intolerances of progesterones and maybe the injection or the Mirena coil in the past or the pill. And they might see how you were when you had estrogen withdrawal. So sometimes women who've had, react badly after the birth of a baby to the withdrawal of all the hormones and get depressed, we might be worrying about their mood when they're in their menopausal years as well. Family history is important, but family history of anything is not a reason you can't take HRT. So if your sister had breast cancer, your mother had breast cancer, it doesn't necessarily mean you can't take HRT. You can't be cavalier, go on it. You have to be very mindful and you have to be checking yourself. But it's always important to look at the family history. Your social history and so what I mean by that is where you're working, who's at home with you, your family life, your hobbies, your lifestyle. Are you exercising? Stop smoking, reduce your alcohol, all the good things that we can do to live better and feel better. And sometimes at the back of our head, so the very odd patient doesn't respond to HRT and still getting horrific night sweats. And there's still other medical things that can give you night sweats, like lymphoma, like TB. Like at the back of our heads, we have to be wondering, could the woman be hyperthyroid or thyroid be too high? So we have to think about all that. So I often tell the GPs when I'm talking to them to think about all the B's. So we have to look at the woman's bleeding. Does she need cycle control? Has she endometriosis? Do we need to find a kind of HRT regimen where she won't be bleeding and in pain? Babies, so the contraception stuff is still important, especially for the younger women, and they can still fire off an ovulation here and there, and you can't fully guarantee that they're not going to get pregnant. The bones we talked about, and not just the osteoporosis, but that kind of achy joint, old lady joints women describe that responds to HRT. The bone drying genitalia, and I think this is so important. So this is often overlooked, because if you get that syndrome where your vagina becomes very dry and irritated and you find sex uncomfortable, and you're often getting recurrent urinary tract infections, that is a progressive condition that gets worse and worse, and it's so easily treated with topical estrogen. So there's lovely pessaries and there's creams that you can use, and you might need to use them daily for a couple of weeks, and then you can back off, and usually twice a week is enough. But that stuff keeps your vagina structurally well and healthy. And it's kind of, some people describe it as female Viagra, because it means that your vagina is structurally more able for penetration, so it won't be sore, you'll be able to enjoy sex life, and also really importantly, these recurrent urinary tract infections. So urinary tract infections can be very disabling and have you at the doctor the whole time. And to have a chat about really good, investing in a good lubricant for sex is really important as well. And sometimes that is really overlooked. And I always try and make a point of asking women about that. And even if you can't take HRT in a pill or a patch, there's hardly any reason why you can't take vaginal estrogen, and it really can make a huge difference to quality of life. So we've talked about so bliss or boners I talk about, and that's to do with your sex life. And it's really important to talk about that, because that can be a major part of a woman's journey at this stage in her life, where she can feel really upset that suddenly out of the blue, her libido is gone and she's not enjoying her sex life. And she can feel really guilty and upset and confused by that. So it's important to talk about that and see HRT may or may not with that. Breast cancer risk, I always show them that infographic I showed you already. And so it's probably a different conversation for very strong family histories and women in their early 40s and things, but it's something that is worth talking through with your doctor. Blood clots. So we do not like to give women oral HRT that have had blood clots before, but loads and loads of research has been done that it's very safe to give it through the skin. So the pill, patch and gel, even if you've had a blood clot. Most GPs will send you to the Complex Clinic for that. Over 60, we generally take you off oral HRT and try and get you on to the gels, patches, and sprays. Brain fog is another one that we like to talk about. And the good news for that is that most women recover fully with that. So Christine Mackey is big into that. She's a Canadian doctor, and she does lots of research on it. And its research is really reassuring that most women actually do very well with that. And I often think it's nature's way of kind of switching off your brain so you forget how bad the menopause is. And you often hear women say, they say it to the mother, how, if their mother is still alive, and they say, oh, I'm suffering bad the menopause. And the mother will say, well, sure, we never had that in my day. And when you actually remember, you can remember your mother howling at the moon and really having an awful time during her menopause and having no patience with her kids and being very difficult. But I often think that brain fog, it helps you forget how bad you were. The same way with childbirth, when that hormone is withdrawn and you see the baby and you fall in love with the baby, you forget how bad it is and you go back for another baby. And only when you're back in the labor ward, you realize how bad it was again. And then you in turn forget it again. And bigger picture thinking is really important. So the average woman sitting in front of most GPs is going to benefit from HRT. And breast cancer isn't the only issue in town. So if you look at what kills women when they get older, and we're talking about women that survive, and if our life expectancy is going to be survived, we might be all alive, please God, in our 80s. But we want healthy bones and we want to be well, and don't want to be having strokes and heart attacks. And HRT is part of the protection there. So if you look at what kills women, like lung cancer and bowel cancer are high up there. Bowel cancer, HRT in general is good for bowel cancer and reduces the rates somewhat. So breast cancer is up there because it's one of the commonest cancers. So 14% of women will get it at some stage in their lives. But things that HRT help are very high up on the list. So heart attack, stroke, and fractured hip, which is a disaster in many people. And we have to remember that. Examination is important. So blood pressure is necessary for oral HRT, not as critical for the HRT you give through the skin. We usually like to weigh people, and weight gain in menopause is a big issue. Some women gain up to 2 stone. We always talk about breast exam, self-examination, make sure people are plugged in with breast check. And often we sometimes consider other causes for depression, or maybe doing depression scores, because some women can have depression that it doesn't respond to HRT. So I spend my life talking to women who feel they haven't been heard, they want to try HRT, and they respond very well to it and their mood improves. But there are a cohort of women that need a little bit of help and they need counselling. Sometimes they need medication as well. So we have to leave room for that. Pelvic exams are rarely necessary unless you're worried about unscheduled bleeding or there's something you're worried going on. But all of this stuff really comes down to you talking to your GP, because the bloods aren't very helpful. So blood levels, like your hormone levels, are really important when you're under 40, because we have to catch that diagnosis. Because if you're going through the menopause under 40, we like that on paper. We like to see the blood results to prove it, because it's a different entity. Because those young women that go through that change under 40, we worry about their heart attack and stroke risk and their hip fracture risk in the future. And we really want to catch it and get them on higher dose hormones as soon as possible. But bloods other than that can be largely meaningless. And you can be very perimenopausal, have beautiful looking bloods at 12 o'clock, and by 3:30 that afternoon, the bloods look appalling. And if we don't catch you in that window, they're not helpful. So this is where the GP has to kind of trust women and go on their reported symptoms and try and go, this is my magic scale that tells everyone it's 52 kilograms. I can't throw it out because everyone loves standing on it and it makes you feel good. But no one likes being weighed in general, but no one likes being weighed around the menopause. So what makes it your GP level of care? So that would be down to the GP's confidence with it, maybe, and experience and education and up-to-datedness. But what makes it complex menopause? We've already discussed that. So big things are breast cancer, previous heart attack and stroke. Hard no is sometimes necessary. So sometimes it's hard, it's important to say to women that HRT isn't going to help this case, and we'd be too worried about it if we gave it to you. But there's lots of other options that we could exhaust before, there's always something you can offer. Some GPs would be uncomfortable about off-piste, off-license use of licensed products. So, for example, testosterone isn't licensed in Ireland yet, and there is no nice licensed product for females. But we end up using the testosterone that we would use for a man whose testes were removed or who stopped producing testosterone. We use tiny doses so a man would use 2 sachets a day, whereas a woman would use 3 sachets a month. Of the Testogel that we normally prescribe. But that is down to GP because we're not really covered indemnity-wise unless you've kind of done the menopause training. Because that's not licensed use. Now it's licensed for use in men, but not licensed for use in women. And a lot of women seek testosterone. And, for the young, lean women in my practice that I would, in my experience, so women that are younger, that go through the premature menopause or that they're in their early 40s and they're suffering a lot. And if they're lean and they do a lot of exercise, they often feel much better on testosterone. So their libido will improve. And sometimes they feel their brain fog is improved, but it's very hit and miss, and the evidence isn't great for it, probably because it's hard to study. On top of everything else, libido can be quite abstract as well as brain fog. But there is a cohort of women who come back and love their testosterone and don't want to be off it. The menopause hubs are dotted around the country, so we are lucky to have one in Nenagh. So Dr. Casey and myself work there with Ashley Mulcahy, the CNS. Who's the specialist nurse. But there is menopause care happening in loads of GP surgeries, and more you see interested cardiologists that know that HRT can have a protective role in women who have bad family histories. And we do worry about women who have had breast cancer treatment and their cardiovascular risk. So there's often complex conversations that have to happen. And also in the oncology clinics, because you might see women that have had various cancer treatments in the past, and then they're worried about going on HRT. So we have to be careful and we have to be mindful and we have to look at the evidence. And sometimes they need to come to the complex clinic. And the access to specialist menopause care is variable around the country, but now we have all got this pathway that you can go to the acute gynae, the ambulatory gynae unit in Nenagh, where we have our complex hub. You have to be referred from your GP, and it goes through a thing called HealthLink, and we look at the referrals and we do our best. And for your GP, if they need peer support, so I run a Telegram group with there's over 1,000 members on it, 1,000 GPs and practice nurses and various doctors, and they can post questions into that every day. So there's often questions like, I can't get the patch locally, what's the conversion to the gel, what's the conversion to the spray, and we would help them out with all of that kind of stuff. So there's loads and loads of support, and the Menopause Society of Ireland has been revamped this year with Deirdre Lundy, who's at the head, and we all know Deirdre Lundy, our national treasure, who was the head in the COOM, and she's an expert in sexual and reproductive health, and she's someone that has been very helpful to a lot of the other menopause clinicians in the country and has shown tremendous leadership, and she is very active on that group as well. So my take-home message, big thing is that genital urinary symptom menopause, if you've dryness down below, it's progressive and neglected and so treatable. Get onto your GP. The GP there's rarely any reason why you can't take that. And it's easy to forget about it when we all focus on the big kind of, the night sweats and the insomnia and the symptoms that are more florid and get the attention. Okay, and there are lots of rules. So the GP will know all of these. Under 50, if you're bleeding, over 50, if you're bleeding, there's different regimens. So there's a bleeding regimen, a non-bleed regimen. You have to kind of deal with the contraception as well, as I've mentioned. We like people who are over 60 to get off the orals and get onto a transdermal or through the skin prep. Pregnancy risk and contraceptive risk and HRT. So HRT isn't a contraceptive. Some contraceptives are HRT, but not HRT. The pure HRT is actually sometimes maybe even pro fertility. So we have to be careful with that. And we don't stop all the contraceptives till we're 55. The Mirena is for 5 years, so sometimes it's to be topped up after that. So any bleeding problems, as I said, with HRT, if it's great at symptom relief, not so great at controlling the bleeding. So sometimes you need things like the Marina, and sometimes we need to recruit the gynecologist and do hysteroscopies and do ablations or burn back some of the womb lining if it's giving us trouble. And with endometriosis, we know that awful condition where you get very bad pain with your period, we aim to get them on non-bleed formulations. And if your womb is removed, you might need any progesterone at all, which is good news. But sometimes if we're not sure if they've left a little bit of the womb, we give you a trial of cyclical. So that's the HRT. We have the same estrogen every day, but progesterone for 2 weeks of the month. And we see if we induce a little withdrawal bleed. And if we do, we leave you on the progesterone. If we don't, we're fairly certain that we can just leave you on the estrogen alone. So you need to have kind of an expansive kind of open mind when you talk about HRT. And I always say the backbone, funny bone, and wishbone. We have to think about the bones. We have to think about keeping these women as well and as healthy as they can be. And we don't want them fracturing their hips. And the big thing is the broader stroke. So if you look at what kills women, so dementia is high up there. So some of the dementias are, especially the vascular dementia, is very responsive to HRT, we would hope, because you mind those arteries. It's, there's high up on the list is heart attack and stroke. HRT can protect those if you get in within the 10 years of the last menstrual period. So if you get at them before they're 60 with HRT. It's helpful for bowel cancer, and lung cancer and bowel cancer kill women a lot. They're high up on the list of what kills women. But look at the frailty stuff. So the falls and unintentional injury, you can do a woman a big favor by having her bones as healthy as they can be with good quality modern HRT. And just to make the point about that HRT and protection of the arteries, a lot of it's based on that ELITE study, and it shows that if you catch women within 10 years of their menopause, so their menopause, their final period, so generally around 50 to 60, if you catch them in that window, you're still going to get the protective effect of HRT. All right, just to say that I'm not talking through my hat, and a lot of this is evidence-based, or this is evidence-based talk, and here are some of the references. And just to acknowledge Deirdre Lundy and Nicola Cochrane, who are national treasures and giants in HRT care education, and they're just leaders in the country. And they've been wonderful sponsors to me and mentors. Thank you very much. I'm going to finish there. Thanks.
We've a tight schedule, but thank you very much. You've given us a lot of food for thought there, Brian, and a lot of, I suppose, encouragement to take control of our own menopause and come well prepared to our GP for support. Thank you. We now have another one of our community contributor videos that we're going to share with you.
Well, we would have conversation in work, like amongst ourselves. Say those of us that would have gone through it or been going through it. Like, it's not something that would be talked about at home. It's just like when we're in work, we'd feel confident in talking about, just what we're going through ourselves.
The best support I had was I have a very good friend at work, and much of the same age. And I think the emotional support from somebody like that is absolutely huge if you have somebody that you can actually speak to. And secondly, my GP. So I think the day I went to her and I thankfully had the courage to say to her, she just gave me as much time as possible. She was absolutely amazing. And I think the support of a good GP is, and a friend, I think to have a friend is hugely as well, huge as well.
It can be alternative treatments, it can be cognitive behavioural therapy, it can be doing your yoga, it can be doing your exercise, going out for a walk, meeting your friends.
My GP was actually a very good sport, he was, yeah, because I felt he had a lot of knowledge about, menopause and women, and, he was involved in different things with menopause as well, I suppose, so it was actually great to get that help.
Thank you to our contributors there. I think what they share there is something that we can all identify with in terms of their support. Our next expert speaker is Dr. Eimear Farrell, who's a senior clinical psychologist with the HSE Mid West, and Eimear will talk to us about menopause and your mental well-being.
Great, thanks for that. So I'm just going to talk a little bit about how we can mind ourselves from a psychological perspective through the menopause transition. I suppose, as a few speakers have referred to earlier, and some of the women who contributed in the videos, that the menopause transition time can be a perfect storm for us as women, because it's often a time when we are juggling multiple responsibilities, often caring for elderly parents. We might be parenting teenagers or having that life transition, children leaving home. Often we're taking on more leadership roles or increased responsibility at work. There might be issues in our relationships. It's often a time couples separate or have marital difficulties, and we might be learning to deal with being single again. And also our extended family may have health issues. We might have our own health issues. There might be financial stresses. So it can be a challenging time, on top of the fact that we're going through all those hormonal changes. So I'm just going to talk a little bit about managing hot flushes using CBT. Dr. Casey mentioned that CBT is one of the non-pharmacological approaches that has a lot of evidence. So it's just in terms of what is a hot flush. It can feel like a sensation of intense heat or sweating or palpitations or shivering, or that temperature fluctuation. So going from feeling very hot to feeling very cold. And that, can be very distressing for people. So I suppose we know that women tell us that it can cause embarrassment and discomfort. It also can disrupt sleep, and it can set up a cycle where we're feeling very anxious about what happens if we have hot flush. So, like Dr. Casey and a few other speakers have said, it's the estrogen level fluctuation that causes them. And when our estrogen levels start to fluctuate, it impacts on our body's ability to control temperature. So our bodies become temporarily very sensitive to small fluctuations in body temperatures. And we know about 75% of women can have them, and about 30% have a lot of them. So the other thing to bear in mind is that if we're under stress, our threshold for hot flushes narrows. So learning to manage our stress is really important, because the more stressed we are, the more likely we're going to have hot flushes. So I think it's really important to say it's not your fault and you didn't do anything wrong if you're experiencing any of the symptoms we've been discussing tonight, but there are things that you can do about it. And I suppose just in terms of thinking about what happens with the hot flush, it starts with our physical symptoms, like this diagram shows. We might have hot flushes, we might have palpitations, and then we might have the thoughts that come with that, like everyone is looking at me, I can't cope, this is embarrassing. And then when we have those thoughts, the feelings that go with that, like I've said, is like being anxious or worried about it, feeling embarrassed or feeling out of control. And then when we have those feelings, we're more likely to engage in avoidance behaviors, like leaving the situation, leaving the room, not taking up offers to socialize or do presentations at work. So I think what's really important to remember in all this is what you say to yourself about your symptoms and your emotional reactions really matter. So I'm just going to talk a little bit about that now. So what we know is that, understandably, we can have thoughts like, oh no, here we go again, I can't cope, when we have a hot flush. And if we can just try and notice how we're thinking about our hot flushes and say things like, let's deal with this one flush at a time. These symptoms are uncomfortable, but I can manage them. Another common, thought that we can have that it causes us distress is the idea that, oh, everyone is looking at me. And I suppose it's important to remember that, I'm definitely noticing if it's happening way more than anyone else. And they may not even notice. And even if they do, they're very unlikely to be judging you. Another common thought that people can have is that I'm out of control. And I suppose we need to remember there are things I can do to take back some control, like the clothes that we wear, wearing lighter clothes, wearing layers, opening the window. Some people find things like spicy food or too much alcohol can impact on their threshold for hot flushes. And then we can get into very negative thinking, understandably, like these flushes will go on forever. I'll never get over this. And it's important, if we can't accept the hot flush will pass and they will gradually reduce over time. And there's a technique called pace breathing. I'm just going to do a little bit at the end of it that can help us to manage the hot flush in the moment. So I'm going to take us through an exercise now called pace breathing. And so I just want you to, if you can, we've been sitting and listening for a while now, if you can maybe sit back and make yourself comfortable and sit with your feet flat on the floor and with your chest open. And let's gently bring our focus of attention to slowing down the breath. See if you can keep your chest and shoulders still. If you like, you can try putting one hand on your chest and one hand on your stomach to help you get used to this way of breathing. As we begin to take slower and deeper breaths, see if the hand on your chest can stay still and allow the hand on your stomach to gently rise and fall in line with your breaths. Take a few slow, gentle breaths. Allowing yourself to breathe down, slowing down the breath even further. And see if you can gently bring a soothing rhythm to your breath, a rhythm that feels comfortable for your body. Notice the sensations that are present as you breathe in and out. And when your attention becomes distracted, bring it back to the focus on your breath in a kind and gentle way. After a few more breaths, let's begin to see what it feels like to imagine that as you breathe out, feel your body slowing down a little. Or maybe as you breathe out, just notice that you're resting on a chair and your feet are on the floor. Breathing down deep into your belly. Let's see if we can continue breathing like this for a few more moments. Bringing our attention to the sense of slowing down the body, slowing down the mind. Mindfully notice when your awareness is distracted from your breath. And gently bringing your attention back to rest in the flow of your soothing breath. So now slowly and gently, let's allow this practice to come to a close. Remembering at any time, in any situation, we can slow down our breath, which helps us feel calmer and more at ease. And it's just worth noticing that that takes practice, you know, that it may not work immediately, particularly if we're in a highly stressed situation. But the breath is a tool that we have with us anytime, and just slowing down the breath, even for a minute or two, does change our physiology and calm our nervous system. And people who did take part in the CBT program for coping with hot flushes found that this breathing technique was one of the most helpful ones that they learned, because it was portable and people could bring it with them. Okay, thank you.
And again, like I said, I suppose if you grew up hearing that conversation, then you'd feel comfortable, you know, talking about it, like.
And it's not a silent thing anymore that people are saying, you know, but something, it's real, and everybody, you know, in their mid-40s, 50s, whatever, they're going through this. And it's hard to deal with it, I think. You know, not everyone, everyone's journey is different.
I haven't really heard, like I wouldn't be at the age to experience menopause myself, but at the same time, it's handy to know for a future, like for younger people to know what to expect and to be able to deal with it when the time comes for myself and people the same age group as me.
But like, it's giving people ideas too. If you're never going through something like that, you're sitting down, you're listening to people like you know, like what they're going through and what we will expect to go through ourselves, like when it does happen, like. So like, that's good, like, to talk about it. But like, some people don't talk about it because it is a personal thing. So like, it's good women to talk about it.
I would like them to know that firstly that they are enough, that you are enough, and that the value you have in yourself is very much underrated.
Thank you to Eimear. It was really wonderful to practice paced breathing and experience the benefits of that even in the middle of a webinar. Our final group of speakers are from our Health and Wellbeing team. They are Sinead Colleen, Health Promotion and Improvement Officer, who will talk about the importance of being physically active. We have Christine Gurness, Senior Community Dietitian, who will talk about the importance of healthy eating. Gina O'Brien, who is a counsellor with our Integrated Alcohol Service, will outline the importance of paying attention to our alcohol intake. Rachel Meskel, Senior Health Promotion and Improvement Officer, will talk about our Stop Smoking services. And then our last speaker is myself, and I will be encouraging us all to mind our sexual well-being during this time.
We've heard tonight that being physically active helps during the menopause journey, and our speakers have discussed some of the health conditions that we are at greater risk of in perimenopause and menopause. So why be physically active? The research shows that being physically active has a positive effect on our mental well-being, helps us maintain a healthy weight, protects our bones, and reduces our risk of developing disease of the heart. Being physically active can take many different forms. It might be an exercise class in your local gym, morning jog, or 10-minute walk at lunchtime. The changes to our body as we get older and during menopause means we need to do different types of physical activity. There's all different types of physical activity. Aerobic exercise like walking and jogging involves loading the bones and helps reduce our risk of developing osteoporosis. While cycling and swimming are examples of non-weight bearing aerobic exercise. The other types of exercises are strengthening exercises, where we contract our muscles against some form of resistance. This resistance might be your own body weight, a dumbbell or gravity. These type of exercises help us to maintain muscle mass. Balance and flexibility exercises also have an important role to play. They help reduce our risk of falls and keep the motion that's in our joints. Balance exercises are particularly important if our other systems like our vision and our hearing, which help us with our balance, aren't working as well. The Every Move Counts guideline sets out how much and how often we need to do the different types of exercise to help our physical and mental health. While more is better again, it is important to remember there's no smallest amount of physical activity that we need to do to get health benefits. Even aiming for 10 minutes at a time is of use. We also need to look at breaking up the time we spend sitting over the day with some movement, as we now understand better how sitting for too long can be harmful to our health. The HSE Health and Wellbeing YouTube channel have free online exercise videos suitable for beginners and designed by qualified exercise professionals. If you go into your internet search engine and type HSE exercise videos, it will bring you to where all these videos are. There's chair yoga, Pilates, strength and conditioning. Joining a group can also support us when starting to change our physical activity levels. The local sports partnerships in Limerick, Clare and Tipperary provide a variety of group exercise programs in different locations. To check out what might be running in your area, simply phone your local sports partnership or check out the Sport Ireland website to find your nearest partnership. So remember, whatever you choose to do, pick something in an environment that motivates you, that you enjoy doing, that fits in with your day-to-day routine. That way you give yourself the best chance to sticking with it and getting all the benefits we know that being physically active brings.
Hi, my name's Christine Gurnett. I'm a community dietitian in health promotion. I did a video previously of menopause. In that video, I discussed many symptoms and 2 major health risks that menopause can increase, and that's osteoporosis and cardiac disease. I talked about how a healthy diet, especially a Mediterranean-style one, can help reduce these risks and some of the menopause symptoms. Here's a link to that previous video. Along with other factors, menopause is often blamed for weight gain, but weight gain is actually much more of an aging factor. Around the same age when women are entering menopause, there are aging factors emerging like slowing metabolism, loss of muscle mass, and decreasing physical activity. Both men and women commonly gain a kilo or 2 a year at this time of life. The biggest difference for women is that menopause changes our shape. The changing levels in our hormones cause us to store our weight around the middle rather than spreading it around. That's why we really notice it. But muscle burns more calories than fat, and even if our weight stays around the same as it was before, then we may notice our waists are getting a bit bigger. The important thing, though, to remember is that although weight gain is common around the time of menopause, it doesn't have to be inevitable. Weight gain is determined by many factors. Genes play a big role, but there are many other factors too. For instance, making sure you stay active and maintain your muscle is important, as when we lose muscle, we replace it with fat. Stay as active as you can, and I think Sinead's referred to some of our videos on the HSE website. They're excellent, short, simple strength training and conditioning videos, and you can follow these at home without joining a gym or buying special equipment or clothing. Your sleep pattern is very important. There's lots of evidence linking disrupted sleep or lack of sleep with weight gain. We should practice good sleep hygiene. Stress is another factor. When we're stressed, we tend to comfort eat, and we eat more high-calorie snacks, or maybe we skip meals and binge. Try some mindfulness or yoga, or maybe some stress reduction techniques to manage your stress. Then, watch out for the caffeine. Caffeine is very disruptive to our sleep pattern, and it's active in your body for up to 8 hours. It's helpful to cut down on caffeine after 2 or 3 o'clock in the afternoon. Eating lots of fruit and vegetables in your food plan is very important. The majority of people in Ireland don't get enough, or the 5 to 7 that's recommended. The easy way to encourage this is to make sure that at least half of your plate at every meal is fruits or vegetables. The Mediterranean diet has healthy benefits for us too, so add some oily fish and some nuts and seeds into your daily plan. Despite what current fads tell us, don't forget about our carbs for your energy, for fibre, and for weight management. Aging can cause our GI system to slow and we suffer from constipation. We need plenty of fibre and water to get things moving and stay regular. Fibre helps us to feel full and satisfied, and there's lots of evidence that complex carbs or whole grains help us in keeping a healthy weight. Carbs are our body's best energy foods. Without carbs, we find energy elsewhere and we take it from our muscle stores. Complex carbs are important for this and for B vitamins and gut bacteria. So add those whole grains to your daily food plan. Beware of those fad diets. There are many times they come around in different guises every couple of years. If they worked, we wouldn't need to keep reinventing them. Remember, however popular new diets are, the healthy eating guidelines have been around for 60 years or more. Those messages are: follow the food guide pyramid and guidelines for variety, moderation, and balance. Eat your 3 regular meals a day, plan them ahead, eat slowly, enjoy, and feel satisfied but not stuffed. Choose lower fat, sugar, and salt options for meals, snacks, and for drinks. Keep an eye on your portion sizes and calories. Start small, as you can always have seconds. Make healthy snacks something that you take with you to work or if you're out and about. Fruit works well. And then don't forget to move more. Currently, menopause supplements and miracle diets are big money makers. But there's no amount of supplement that will make up for an unhealthy diet. Here's a link to our Irish food guide pyramid. This will help you to plan a healthy eating pattern, and there's lots of evidence behind it. One thing to remember to maintain our health as we age is to make healthy eating a priority. Usually, as we are aging, we may not burn enough calories like we used to. When making changes, it's important to make small changes so that we can stick to them in the long term. However, we're only human and not perfect, so we need to work on accepting our ever-changing bodies. Most importantly, remember to embrace the newer, wiser, stronger you and enjoy your second spring.
Hi, my name is Gina O'Brien. I'm a counsellor working in the Mid West Integrated Alcohol Service. The World Health Organization says that there is no healthy or safe amount of alcohol, but the HSE current low-risk guidelines for women say that women should consume no more than 11 standard units per week. 1 standard unit is considered a half pint of beer, stout or ale, a single measure of spirits, or 1 small glass of wine. During menopause, alcohol can worsen the physical and mental symptoms. Women are at increased risk of osteoporosis, heart disease, cancer, anxiety and depression. There are a number of tips and techniques that can help you reduce your alcohol use. Keeping an alcohol diary. Note how much you drink, when and why. Choose alcohol-free days. Don't bulk buy alcohol or keep it in the house. Switch to 0% drinks. Switch to a lower alcohol drink, for example, switching wine to beer. Join a group or volunteer. Get active. Get a partner or friend on board to help keep you accountable. We'll post some links to self-help tools and resources at the end. But remember, if you feel you need professional support, just reach out, as support is always available.
Hi, I'm Rachel, and I want to talk to you about stopping smoking, because stopping smoking at any time of life is really important for better health and to live longer. Menopause is an ideal time to stop smoking. By not smoking, you delay the onset of menopause and you reduce the number of hot flushes. Also, more good news, you can decrease the risk of developing osteoporosis and gum disease. The interplay between smoking and bone health is very complex. If you smoke, the risk of bone fracture is increased by 25%. So really good news. There is an entire team of us here at Quit Mid West ready to help you. You can ring us, you can talk to us, and we can support you as you want to stop smoking. So contact us at Quit Mid West. Oh, and just to make sure that we get the point across, they gave me a really, really big sign to hold up. You won't be able to miss this.
Sexual health, menopause and me. Hello, my name is Maher Kelly and I'm a Health Promotion and Improvement Officer with the HSE Mid West, and I have a remit around sexual health promotion. I am based in Limerick. We are all sexual beings, and as we embark on the next phase of our lives as perimenopausal or menopausal women, that doesn't change. What can change for some of us is how we experience ourselves as sexual beings. In the years around menopause, we as women may experience some changes in our sex lives. For some, it is more enjoyable as the fear of unwanted pregnancy abates. For others, they find that they think about sex less often or they don't enjoy it as much. Reducing hormone levels during this time may cause vaginal tissues to become thinner or drier, which may make penetrative sex uncomfortable or painful. There are treatments available to help your symptoms. For example, the use of lubricants greatly enhances the experience of sex. There are a wide variety available over the counter in any pharmacy. Just to be mindful, if you are using condoms during sex, that not all lubricants are safe to use with condoms, as some reduce their effectiveness. Being less interested in sex as you get older is not a medical condition that requires treatment. Libido naturally goes up and down during one's life course. However, if changes in your sexual health bother you, I recommend that you talk to your GP or practice nurse or other supports that may be available in your area about possible ways to help. Sexual pleasure is a much neglected yet fundamental part of sexual health. Research indicates that sexual pleasure contributes to the quality of life and the quality of intimate relationships, both of which support individual and societal well-being. There are many ways to achieve sexual pleasure. Penetrative sex isn't the only way. Touching, stroking, massaging, kissing are some of the many ways in which sexual pleasure can be shared. The key message is to be kind to yourself, to know what's right for you and to enjoy it. I invite you all to own your own sexual pleasure destiny and be creative in how you want to be pleasured and give pleasure in a safe, consensual way. Thank you to all our health and wellbeing contributors for inviting us to look at our own lifestyle behaviours and how by making small changes we can improve our overall health and well-being during perimenopause and menopause. Our closing video this evening is Anya Collins, who really sums up this part of our lives very well.
Let's face it, every woman is going to go through menopause. And it's up to every woman to equip themselves with the knowledge that I am going to go through this. It's the acceptance piece. And to know that there is so much out there, so many specialist people who are specially trained in this area to help you with your symptoms. Every woman has different symptoms. No, there is no one size fits all. And there is someone there to listen to. There is help available. It's not to fear it. It's not to be feared anymore. And it's to know what to take with specialist advice and live your best life, basically.
We have reached our question and answer stage of the evening. So I would like to invite and welcome our panelists who will be joining us for this. So we will have Dr. Cathy Casey, Consultant Obstetrician and Gynaecologist. We have Dr. Brian Kennedy, GP and Menopause Specialist. Aisling Mulcahy, Clinical Nurse Specialist with the Complex Menopause Clinic. Maher, who Clinical Specialist Pelvic Floor Physiotherapist. And Dr. Eimear Farrell, Senior Clinical Psychologist with us here in the HSE. Can I also draw your attention to our closing poll at the end of the webinar? Can I invite you all please to complete, as your answers will inform our further programmes of work around menopause in the Midwest. We have had a very successful evening this evening. We've had over 1,000 people attending and submitting questions. So thank you to everyone. But because of the number of questions, we will not be able to answer all of them. So we will be just pulling a selection of them for our panelists to answer. So if it's okay, we will begin, and I will pose our first question to you, Dr. Casey, if that's okay. And the question is, I find myself very cold with the menopause. Is this common?
It can happen, absolutely. Most of the women will complain of heat, but then there's the shivering and cold aspect to it also. So yes, it can happen, and it is one of the menopausal symptoms.
Okay, thank you. Brian, I have a question here for you. I still have my periods. My GP says I can't be menopausal. I feel I am. What can I do?
So that's simply not true. You can have your periods and be menopausal. So you can have your period every month and have hot sweats and flashes. And there is no blood test to prove that. So that involves the clinician kind of believing your symptoms and maybe giving you a trial of estrogen to stabilize out your estrogen so that you never fall below a certain level and see if that improves. Just to add to Cathy's answer there, I'd say that's the equivalent. Like if that woman went into the average menopause clinic and she was cold all the time, it'd be like sitting in a clinic with your perfect baby that never cries beside a colicky woman. I think they'd all be very jealous. But the vast majority of women would have a lot of flashes and hot. So cold is interesting, but I'd wonder, should she check her thyroid as well, you know?
Okay, thank you. I'm going to go to you, Michelle, with our next question, if that's okay. What the possible causes of pelvic pain in a 45-year-old woman who has had an internal and external ultrasound with normal results?
Okay, well, I suppose firstly, I would probably need to know a little bit more about this particular lady's symptoms to give her a concrete answer there. It's great that she has had her internal ultrasound scan done. So I suppose from a physio point of view, potentially it could be down to the declining levels of estrogen causing vaginal dryness, perhaps painful intercourse, perhaps down to the thinning of her tissues. I suppose really what I would recommend there is her having a referral to a pelvic health physiotherapist to do an in-depth exam where we would go through her symptoms in detail and perform a physical assessment with her. Outside of that, obviously suggesting that her GP has ruled out all other possible causes.
Okay, thank you. Does anybody else want to add anything to that, or? No, okay. Aisling, just a question for you. I am wondering if there's a possible link between migraine and menopause, particularly if you got headaches, at the time of periods.
I might actually give that one to Dr. Casey or Dr. Kennedy.
Okay.
I'm happy to take that. Yeah. I think when you have menstrual migraine, in other words, period migraine that occurs coming up to a period or during a period, that usually settles down and stops once the periods stop. So once they go into menopause, the migraine can ease. But you can get women who are still getting migraine through menopause. And in that situation, then they can take HRT, but it needs to be monitored closely. And there are certain associations with migraine, like if they're getting aura, we have to be very careful. But if their symptoms are severe enough that it's interfering with their quality of life and other options may not be available to them, then it's something that we would treat, but it does need to be monitored closely. But the typical menstrual migraine will settle at the time of menopause.
Okay, thank you. Eimear, for you, a question came in. How would you know the difference between severe anxiety and menopausal symptoms?
Oh, it's a great question, isn't it? Yeah, I mean, I guess it depends on, is it a sudden onset, or is it something someone's been struggling with for a few years, or that they previously had episodes of anxiety. But it is part of the menopause symptoms. So I guess it's definitely worth talking to the GP, maybe thinking about some of the HRT options to see, does that reduce it, as well as using things like the pace breathing, and some of the CBT techniques around dealing with catastrophizing, or just, keeping a diary of what your anxious thoughts are and what you might say to a friend. But this is the thing. I think it's hard to differentiate what's the underlying cause, whether it's, an underlying anxiety disorder, or whether actually it's to do with the menopause symptoms.
Okay. I think what's coming through very strongly here is the need for us all as individuals to contact our GP first as the first point, and then allow that then to refer us into other services. That would be. Aisling, this one is in relation to the Complex Menopause Clinic, and what is the waiting list like?
Yeah, so with the waiting list, when we get the letters, we have to vet them, and we vet them as either urgent, semi-urgent, or non-urgent. And at the moment, the non-urgent, you're looking at around 6 months.
Okay. We've one final question, because time is, and that is, and I'll just put it open to all of you. If you are managing menopause fine, should you take HRT to reduce your risk of other diseases? For example, heart disease, cancer, osteoporosis.
Do you want me to go first on that, since I'm...
Yeah, that'd be great. Thank you.
I think the most important thing is that we're all, from the guidelines and from the recommendations from the various colleges, that HRT is indicated for symptoms, and it is used to treat symptoms. There is no doubt that it has the beneficial effect on other conditions, but lifestyle, diet and exercise are very important, and they would be the first line. But if somebody has, mild symptoms, and there is an issue that where they are at risk of developing osteoporosis or heart disease, then yes, HRT can be used. And it is a gold standard treatment for osteoporosis in the peri and early menopausal women. But as they get older, they move on to other treatments. But I would stress that lifestyle, diet and exercise, really important to reduce a woman's risk of disease going forward.
Okay, thank you.
And I would maybe add to that the rules are different if you're under 40. So if you're under 40 and you're very young, we'd be very pushy with the HRT. And if you're kind of an early menopause, you're 40 to 45, we'd still be encouraging if we can find an excuse to give it to you. And over 45, it generally becomes a discretionary medication that's not absolutely necessary. But it's often worth maybe doing something like maybe getting a DEXA scan. So women might find, if my bones are thin, that might push them into maybe thinking, I'll go HRT. But I think one of the big things around that is the age, I think, at menopause. Yeah.
I think it's vital. You're right, Brian. I think premature ovarian insufficiency is a separate condition altogether to what we're talking about tonight. There is no doubt that if a woman is without estrogen and she's under 40, or indeed some of them in the early 40s, they are significantly more at risk of long-term illness, and they should be on a HRT until they would reach the normal age of menopause at the age of 50 or 51. They're a completely separate entity to what we are dealing with tonight.
Yeah.
Okay.
And also to just colour that 20% of women actually don't mind the menopause, and sometimes they're very relieved by it because their hormones can be very difficult to deal with.
Mm-hmm.
And so it's not always something that needs interference or medical intervention,
Okay, thank you. And sorry, this is definitely the final question, and it's in relation to HRT and the talk about HRT. When is the free HRT becoming available, or do you have any update on that for all of us here?
So at the moment, we still have no update on that. We're all looking forward to January, to the free HRT. As we know, that hasn't happened. Now, I have reached out to our local TD here in Nenagh, and they were speaking to the Minister of Health to see what's happening. So we're in the dark. I think we're all in the dark. I think just keep the pressure on. We were promised this, so we just need to keep the momentum going for us women of Ireland and the Mid West.
Okay, so wait and hope. That's
and a bit of pressure.
And a bit of pressure. Okay.
Yeah.
Okay, thank you very, very much to all of you. We have now come to the end of our webinar, to our evening. I'd like Firstly, to thank all our speakers, our panelists and contributors for giving their time, their expertise and for sharing their experience. Secondly, I wish to thank the following for making this webinar happen: the working group who worked tirelessly to make this a reality over the past few months, to thank the HSE Mid West, the Complex Menopause Clinic, to thank our Head of Service here in Health and Wellbeing, Niamh Wallace, to thank our broader Health and Wellbeing team, our bridge interpreters and IMS. But finally, I want to thank you, our audience, for joining us here this evening. We had over 1,000 viewers here this evening, and I really hope that there was something here for all of you. So have a lovely evening and take care. Bye.